All right, welcome everyone. Thank you for joining us today. Very happy to be here, and thanks for taking time out of your busy evenings after a very long day of sessions to join us this evening. Honored to be here as well in person. That I was able to make the trip over from the U.S. and also happy and looking forward to the program tonight. Tonight we have Dr. William Audeh joining us. He's our Chief Medical Officer from India. And he's joining us from the west coast of the U.S. So over there it's about 3:30 in the morning. But so thank you again, Dr. Audeh, for joining us. Yeah, looking forward to the program. But without further ado, I'll hand over to you, Dr. Audeh.
All right, thank you. And I am sorry I cannot be there to enjoy what I'm sure was a nice dinner. But I'm coming to you, as Joe said, from the other end of the Pacific. And I'm happy to be able to discuss with you the use of MammaPrint and Blueprint to redefine patient outcomes in early stage breast cancer with real world cases as examples of how these assays apply. I'd like to begin by putting what I'm going to talk about into the context of breast cancer in general. And of course, I have practiced in the US, and I can say that most women diagnosed in the United States with breast cancer are diagnosed at a curable stage. I think that's the case in many areas around the world. And in that situation, the challenge is to achieve cure with the least toxicity and the least effect on quality of life. So precision in breast cancer diagnosis and classification is essential to achieve that goal, to avoid overtreatment and undertreatment, to achieve the best outcomes with the selection of the right therapy for the right patient. Now, in order to achieve the best outcomes, of course, we need to define breast cancer, as I said, with the greatest precision. We will continue to rely always on basic classical, clinical, and pathologic features that define breast cancer as we understand it. The clinical stage, the pathologic stage, the histologic subtype of ductal, lobular, and other subtypes, and then the first classification based upon molecular subtypes on surface markers, estrogen receptor, progesterone receptor, and HER2, or the lack of them all in triple negative. But I'm sure you'll agree that that still leaves us unaware of what is going on at the level of the genome in these cancers, which is where the pathology really is. And that is why having a tool to look at the genomic level is so critical. And that's what I'd like to discuss with you, comprehensive gene expression profiling, looking at 150 genes in breast cancer that provide clinically meaningful information to supplement what we learn from pathology. So when we look at the standard diagnostic categories based upon hormone receptors and HER2, we then add MammaPrint and Blueprint to further classify tumors in ways that are clinically relevant, as I will show you. So let me just take a moment to quickly review the assays themselves. We think of these as functional genomic profiling of breast cancer. The MammaPrint defines the potential for distant metastasis, and we separate tumors into either low risk or high risk of distant metastasis based on 70 genes within the MammaPrint assay. Here is a diagram of the metastatic cascade, as it is called, at least 7 distinct steps, which are each biologically complicated. And what we now know, of course, is that the 70 genes within MammaPrint, which were developed to predict the risk of distant metastasis, these 70 genes participate in one or more of these 7 steps in the metastatic process, beginning with growth and proliferation at the primary site through multiple steps that I'm sure you're all familiar with, until at the end there is a micrometastasis landing at a distant site that is capable of growth. This is the metastatic process that MammaPrint analyzes. Our other assay, also a functional genomic assay, is is a subtyping assay known as Blueprint, 80 genes, which identify the signaling pathways driving tumor growth related to the surface protein markers. And so based upon gene expression, which is triggered by activation of the surface markers, we identify tumors as being either luminal type or hormonally driven, HER2 type driven by signaling from the HER2 receptor, or basal type with neither of those signaling pathways active, but with a number of other important genes recognized. One reason that we feel it's very important to look beyond the surface marker, of course, is shown here in the case of estrogen receptor signaling. We will always rely on the presence or absence of the estrogen receptor protein itself to help us define breast cancers and to select therapies. But that by itself is simply not enough to fully understand the biology of breast cancer. There are assays that, as you know, that look at the single gene mRNA of the estrogen receptor. MammaPrint does not look at that specifically because the estrogen receptor mRNA is actually in the Blueprint assay. But within Blueprint, what we see is not simply the estrogen receptor protein, the gene itself, but we see all of the genes downstream that are either turned on or off by an active estrogen receptor. And we feel this is important because, as I will show you, there are estrogen receptor positive breast cancers that have the protein present, but have no signaling. The protein is non-functional. And what you have is actually a basal type tumor, which behaves like a triple negative breast cancer and must be treated differently. So with every sample we receive, we run both of these assays simultaneously and are able to provide a comprehensive classification. Now, in recent years, additional research has allowed us to further stratify MammaPrint into two low-risk categories, ultra low risk and low risk, each of which have clinical implications. And even further, within the high-risk category, we now recognize differences within high risk, and we refer to these as high risk 1 and high risk 2, as the risk index of MammaPrint goes higher into the high risk range. Together with Blueprint, what we provide is further classification of breast cancers beyond standard pathology. And for the purposes of this discussion, I'll focus on the 5 subtypes of estrogen receptor positive breast cancers that we identify: ultra low risk luminal A, low risk luminal A, luminal B high 1 and high 2, and then estrogen receptor positive but genomically basal tumors. I'd also like to point out that our testing is performed on formalin fixed paraffin embedded tissue, not fresh tissue. FFPE tissue is certainly adequate and is the standard of care for our assays. And these assays can be performed on either the definitive surgical resection or increasingly on core needle biopsies prior to surgery, where that information may be helpful. So let me begin with the first of 5 brief cases that I'll review with you. The first case is a 51-year-old woman with stage 2 breast cancer. She is found after surgery to have a 2.5 centimeter invasive ductal cancer with 1 of 5 lymph nodes involved. Her molecular classification is shown here. She's ER/PR positive, HER2 negative, and grade 2. So of course, this stage 2 lymph node positive woman has the question, does she require chemotherapy to achieve cure? And for this, of course, we have our level 1 evidence with MammaPrint from the prospective randomized MINDAC trial. In this trial, we enrolled nearly 7,000 patients, primarily across Europe. The results were first reported in the New England Journal of Medicine in 2016, with the primary endpoint being the 5-year distant metastasis-free interval and survival, which was reported at that time. In 2020 at ASCO, we reported longer-term follow-up, median of 8.7 years, with both 5 and 8-year outcomes. And these data were then published definitively in Lancet Oncology in 2021. And this was the result of that large prospective randomized trial. What we showed was that hormone receptor positive, HER2 negative women with clinically high-risk tumors that were either T2 or node positive or higher grade or some combination of these things, these clinically high-risk women, if they were MammaPrint low risk, they could be safely treated with endocrine therapy alone and without chemotherapy. Shown here is the group that was clinically high risk, MammaPrint low risk, treated with endocrine therapy alone. At 5 years, their distant metastasis-free survival was 95.1%, with the second arm not shown here that received chemotherapy doing the same. In other words, there was no significant additional benefit of chemotherapy, showing definitively that MammaPrint low-risk women may safely avoid chemotherapy regardless of clinical risk and regardless of the presence of 1 to 3 positive nodes. Here is the lymph node positive group separated out. In 2016, we were able to show that for this clinically high MammaPrint low-risk group that had 1 to 3 positive nodes, there was no statistically significant difference between the chemotherapy group in the red line versus the no chemotherapy group in the blue line. On the right is the follow-up with longer-term follow-up, showing that at 5 and 8 years, these data remain robust and durable, with the results consistently showing that these lymph node positive women, if they are MammaPrint low risk, do not benefit from the addition of chemotherapy. Now, these data back in 2016 allowed MammaPrint to be the first genomic assay with prospective randomized data in node positive women, the first assay to be approved by the ASCO guidelines for use in node positive women. And now with the longer term follow-up, MammaPrint remains the only assay with at least 8 years of follow-up in node positive women, unlike any other assay with node positive data. I'll also point out that 1/3 of these women were 50 years or younger. Now, the age issue was raised with the longer term follow-up. We had seen in other large prospective trials with other assays that there seemed to be an effect of age on the benefit of chemotherapy, even in genomically low-risk women. Shown here again from MindAct are those same women, clinically high risk, but MammaPrint low risk, now separated by age, 50 years and younger on the left, over 50 on the right. And what you can now see is that there actually is a benefit to chemotherapy, but only in women 50 years and younger. This benefit shown in the red line does not begin to appear until year 4, which is much later than we typically expect to see chemotherapy effects. And by year 8, the benefit is approximately 5% for chemotherapy. This is in contrast to the women over 50 on the right, with the same clinical high-risk features, the same low-risk MammaPrint, but absolutely no significant benefit of chemotherapy. So why is this? We believe strongly that this is not a direct effect of chemotherapy on the tumor. Otherwise, we would have expected to see the difference appear much earlier, as the Oxford overview data showed. But we're also impressed by the fact that this is only appearing in younger women with functioning ovaries. In other words, we believe that this effect is an indirect effect of chemotherapy, inducing ovarian suppression, which obviously provides an enhanced anti-estrogen effect beyond simply oral tamoxifen And that is the reason we are seeing this additional difference. Because we do believe that this difference is based on indirect secondary ovarian suppression, we apply MammaPrint in this way. For postmenopausal women who are MammaPrint high risk, we believe chemotherapy is, of course, indicated, as well as for premenopausal women. But for postmenopausal women who are clinically high risk and MammaPrint low risk, the data are unequivocally showing that there is no need for chemotherapy. In premenopausal women, clinically high risk and MammaPrint low risk, we believe that there is sufficient doubt as to the real need for chemotherapy that we advise shared decision-making in these women with a discussion of the risks and benefits and the likelihood that ovarian function suppression is indeed the only reason that chemotherapy is providing benefit. And as you know, ovarian suppression can be obtained without using chemotherapy, but using other agents. So to answer this question, does she require chemotherapy to achieve cure if she obtains a MammaPrint and she is fortunate enough to be MammaPrint low risk and by blueprint luminal, she can be safely treated with anti-estrogen therapy alone without chemotherapy. Now, the second case is a somewhat older woman, 72 years old, with stage 1 breast cancer. This tumor is 1.5 centimeters invasive ductal. There is no lymph node involvement by sentinel node analysis. And she is also hormone positive, ER and PR positive, HER2 negative, lower grade. Of course, for her, the recommendation was 5 years of anti-estrogen therapy with an aromatase inhibitor. She has completed 2 years of the planned 5 years of anti-estrogen therapy, but has severe side effects, which I think we're all familiar with, those of us who have treated women with breast cancer with these agents: severe arthralgias, hot flashes, memory loss. This woman is wishing to stop before she's completed her full 5 years of standard of care anti-estrogen therapy. So she asks the question, can her therapy be safely discontinued with less than 5 years? And to answer this question, we actually have important new data with MammaPrint as well. We now recognize within the low risk category an ultra low risk portion of this range. So the entire low risk group, as I showed you previously, can avoid chemotherapy. But now we see further difference in the clinical behavior of these low risk women when we look at the ultra low risk, which is above 0.355 in the positive range, which is our low risk range. This entity was first described in detail in this study published in JAMA Oncology in 2017, in which we looked at one of the older Stockholm tamoxifen trials. This was a trial in which there were 652 postmenopausal women with hormone-positive breast cancer enrolled many years ago in the late 1970s and early 1980s, at a time when investigators were still trying to determine whether adjuvant therapy was necessary for premenopausal women with low-risk tumors. They were randomized in this trial after surgery to no therapy, which was the standard of care at the time, or to primarily 2 years of tamoxifen. This was, of course, many years before aromatase inhibitors were available. In the treated arm, if they tolerated the first 2 years, they could continue for a further 3 years to complete 5. The value of going back to this trial, of course, was that this cohort had 20 years of follow-up, and the tumor blocks were actually available. So we were able to go back and perform MammaPrint on these tumor blocks, extract sufficient mRNA to learn that 15% of these patients were MammaPrint ultra low risk. And now we had 20 years of follow-up with a treated group and an untreated group. And these were the really extraordinary results. We showed that for this postmenopausal clinically low risk group, they had an excellent outcome at 10 and 20 years, showing here the untreated group in the dotted green line and the treated group in the solid green line. So at 10 years, both groups had nearly a 100% breast cancer specific survival. And by year 20, the treated group had a 97% 20-year breast cancer specific survival. The untreated group, treated only with surgery at 20 years, had a 94% breast cancer specific survival. Really an extraordinarily good prognosis group who appeared to do exceedingly well with less than the full 5 years of endocrine therapy for the most part. So we concluded from this trial, which has been validated with additional trials as well, that postmenopausal women with ultra low risk breast cancer may not require a full 5 years of endocrine therapy if they're experiencing significant toxicity, as this woman was. Now, we've had an important update in the data regarding this ultra low risk category that came from the MINDAC trial itself. We published last year, in fact, in the Journal of Clinical Oncology, the ultra low risk cohort for MINDAC, which numbered 1,000 patients, all of whom, as I said, had a MammaPrint ultra low risk of over positive 0.355 in the low risk range. And their results mirrored what we saw in the original Stockholm trial. Here is that same endpoint, breast cancer specific survival, just for the MammaPrint ultra low risk women in MINDAC, those 1,000 women. And you can see that whether they were clinically low risk or clinically high risk as defined by that trial, at 8 years, their breast cancer specific survival was nearly 100%. Now, importantly, we were also able to look at this ultra low risk group stratified by age. So age under 50 years and younger in the blue line, over 50 in the red line, they perform essentially the same. And this is exceedingly important now with the data that I showed previously, showing that there may be a small chemotherapy benefit for premenopausal women, pushing many doctors to now give more chemotherapy and even not consider genomic testing. But here we show that we can identify a group of women 50 years and younger who, if they are ultra low by MammaPrint, clearly do exceedingly well with endocrine therapy alone. The majority of these patients were treated with endocrine therapy alone, or actually no therapy. So at 5 years, their distant metastasis-free interval was 97.1%, 95.6% at 8 years. It is hard to imagine that the addition of chemotherapy with all of its toxicity would have added any significant benefit to this good prognosis group. So we believe that premenopausal women who are ultra low risk by MammaPrint clearly do not require chemotherapy. We're also happy to report that the NCCN guidelines now recognize ultra low as an important subcategory of hormone receptor positive breast cancer that should be considered in decision making for these women. So had this woman had a MammaPrint at the time of her diagnosis, or even now, this question can be answered. Can endocrine therapy be safely discontinued with less than 5 years? In this case, if she were MammaPrint ultra low risk, the answer is yes. She could safely discontinue with the treatment that she's already had and expect an excellent outcome based upon these robust data. And again, the application here in a postmenopausal woman is not to advise that these women not receive anti-estrogen therapy according to standard of care, even if they're ultra low, but to allow them to discontinue early if they appear intolerant of therapy and wish to stop. Third case I'd like to discuss is a 68-year-old woman with stage 2 breast cancer, a 3.1 centimeter invasive ductal cancer, node negative, hormone positive, HER2 negative, intermediate grade. unlike the prior case, this woman is tolerating her anti-estrogen therapy quite well. She understands that the standard of care that is planned for her is 5 years. But she is also aware, as is her physician, that half of all recurrences in hormone receptor positive breast cancer occur after 5 years from diagnosis. In other words, after the standard therapy has been discontinued. So the question can be asked, can recurrence after 5 years be prevented by extending endocrine therapy to 10 years in some women? And to answer this question, we can look now at two large trials. You may recall the NSABP B42 trial, which was designed to answer this question: who benefits from extended endocrine therapy? This trial, as you may recall, enrolled postmenopausal women with hormone receptor positive breast cancer, stage 1, 2, or 3A. They needed to have completed a full 5 years of their adjuvant endocrine therapy. They may also have received chemotherapy initially. And then at the end of 5 years, if they remained disease without any disease-related events, they were then randomized to either an additional 5 years of letrozole or placebo, seeking to determine whether the group receiving the additional endocrine therapy would benefit. And as you may recall, there was a small benefit to the letrozole arm, a 3.3% disease-free survival benefit. But the question was, could we better identify which women really need this extended endocrine therapy with all of the attendant toxicity and risks of osteoporosis, etc.? With such a small benefit, it is difficult to justify or to know which women require this. So the question was raised with us, could genomics identify who benefits? And we did, in fact, analyze the NSABP B42 cohort, and we showed that we could, in fact, better define the group that would really benefit. These data were presented in a plenary oral presentation in ASCO in 2021 and is soon to be published. And what we showed in this important trial was that taking the original B42 cohort that showed a 3.3% disease-free survival benefit at 10 years, by applying MammaPrint, we could separate this group into 3 subgroups: MammaPrint high risk, who did not benefit at all; MammaPrint ultra low risk, whose small benefit was statistically insignificant; and the remaining low risk women who were not ultra low were the only ones that had a benefit to extended endocrine therapy, 9.5% disease-free survival. Now, interestingly, we have now a second large trial known as the IDEAL trial, which showed the same thing. These data were presented at San Antonio just last December in an oral presentation. IDEAL was also an extended endocrine therapy trial, but if you recall, the design was somewhat different. They compared 7.5 years of extended aromatase inhibitor therapy versus 10 years. And you may remember that the original trial, conducted in Europe primarily, was negative. They did not detect a difference based upon clinical factors alone between 7.5 years and 10 years. But when we applied MammaPrint again, as we did to the B42 cohort, we again showed a nearly twofold improvement in distant recurrence in the MammaPrint low risk group that was not ultra low, and a nearly threefold improvement in breast cancer free interval. This mirrors what we saw in B42. So we now have 2 large prospective randomized trials that we looked at retrospectively with MammaPrint, and we're able to show consistently that it is the MammaPrint low risk, not ultra low, group alone that is benefiting significantly more than the unselected group. So for this woman who is tolerant of her anti-estrogen therapy and is asking whether she might benefit from continuing for an additional 5 years, if she were to have a MammaPrint result that was low risk and not ultra low, we could in fact say that if she wishes to achieve that additional protection from a late recurrence, she would indeed be a good candidate for extended endocrine therapy. Let me move on to the next case. A premenopausal woman now, 44 years old, with stage 2 breast cancer, a rather large primary tumor, 4 centimeters, 1 positive node, hormone positive, HER2 negative, intermediate grade. With a large node positive tumor, it's reasonable to ask, is she a candidate for preoperative neoadjuvant therapy? And if so, can gene expression profiling inform this decision regarding the timing of surgery and the use of appropriate preoperative therapy? In general, with neoadjuvant therapy decisions, we look for HER2 positive and triple negative breast cancers as good candidates for neoadjuvant therapy. It is less clear for hormone receptor positive breast cancers, and that is why this genomic information is so useful. So what are the benefits, to digress for a moment, of even considering preoperative or neoadjuvant therapy? Well, I think we all understand that one clear benefit, of course, is the shrinkage of the tumor, reduction in the extent of surgery that may allow for breast conserving surgery when mastectomy may have been required previously. It also clearly can reduce the need for complete axillary dissection in node positive women who clear disease in their nodes with nodal downstaging. And of course, the achievement of a pathologic complete remission is well known to be prognostic. So the standard of care for the clinical indications for neoadjuvant chemotherapy are well known. Regarding the likelihood of pathologic complete remission, neoadjuvant chemotherapy is advised when a high likelihood is expected, as it is in HER2 positive and triple negative breast cancers. But with hormone positive breast cancers, we rarely see a pathologic complete response in the general ER positive group. And here is where the blueprint subtyping assay is most beneficial. These are data from a study referred to as NBreast that we conducted a decade ago, in which we classified over 1,000 tumors using either immunohistochemistry, both immunohistochemistry as well as genomic classification with the MammaPrint blueprint. When we looked at the pathologic complete response rate in the group defined by immunohistochemistry, we saw approximately 10% pathologic complete response to neoadjuvant chemotherapy. When we further stratify these patients using MammaPrint and blueprint, we find that those tumors that are luminal A, which is defined as MammaPrint low risk and blueprint luminal, had only a 2% rate of pathologic complete response. Those that were luminal B, MammaPrint high risk, but hormonally responsive by being luminal, had a somewhat higher rate at 6%. But we did identify a further group with a much higher rate of pathologic complete response, 34%. This group was hormone receptor positive by immunohistochemistry, but they were genomically basal by blueprint. No evidence of estrogen receptor signaling. This group actually made up 29% of hormone positive MammaPrint high risk patients. So what is the biology of this subtype? Well, here we show that as the MammaPrint index becomes more and more negative in the high risk scale, the likelihood of pathologic complete response increases. And this, of course, is what we see with these tumors. You can see here the red dots as we go further and further into the high risk scale allow us to have a higher likelihood of pathologic complete response. Now, we've gone a step further in defining this PCR likelihood in these high-risk patients. And that is to separate the high-risk group into high 1 and high 2, because as you can see, there's an increasing rate of pathologic complete response as we go higher in the risk range. These data were provided to us by another large neoadjuvant trial known as I-SPY, which showed very clearly that MammaPrint high risk predicts sensitivity to chemotherapy as well as other targeted therapies. So in their trial, they also have enrolled nearly 1,000 MammaPrint high risk women. And here, what is shown is the high risk range from 0 to -1. And then as they split the groups into high risk 1, MP1, and high risk 2, the likelihood of pathologic complete response shown in the dark blue boxes doubles when you go from high 1 to high 2. Now we find that the separation actually occurs at -0.57, which is easy to see on any MammaPrint report, exactly where that index falls. And what we've learned from the I-SPY data is that these MammaPrint high-risk tumors not only have an increased rate of pathologic complete response, but they also, interestingly, have increased sensitivity to a variety of agents, carboplatin, immunotherapy, PARP inhibitors, and may have resistance to CDK4/6 inhibitors in this highest end of MammaPrint. So what we believe we have also found are indicators of the highest likelihood of pathologic complete response in estrogen receptor positive breast cancers. Here, in this diagram, I'm showing you not only the pathology classifications, but then the further classifications that MammaPrint and Blueprint provide. And here we know, of course, that HER2 positive tumors and triple negative tumors shown in the two starred categories here are, of course, standard candidates for neoadjuvant therapy. But what MammaPrint and Blueprint provide, as I just showed you, is the identification of two additional groups, those that are hormone positive basal and those that are luminal, but on that highest end of the MammaPrint scale, high 2. And we have shown that these tumors also have high rates of pathologic complete response, high likelihood of nodal downstaging, avoiding axillary dissection. So for this woman, how aggressive is her ER-positive breast cancer, and what type of therapy is most likely to achieve cure? That woman that we just reviewed, I think, is an excellent candidate for neoadjuvant therapy. Now, this last case is a 52-year-old woman with stage 2 breast cancer. She has a 2.5 centimeter invasive ductal cancer with 0 of 4 nodes involved. And I'm giving you a little more detail about her hormone receptor status, because her ER is high, it's 80%, her PR is at 50%, and she's intermediate grade. So as with the previous case, it is important to determine certainly whether she has a high likelihood of a pathologic complete response, but also just how aggressive her tumor is. So not only do we want to know the MammaPrint index, but we also want to know the Blueprint result. So how aggressive is this tumor, and what type of therapy is most likely to achieve cure for her? And again, how can we apply gene expression profiling here? Well, for this assay, Blueprint, I want to show you that we have these 3 signatures, but I want to focus on the luminal signature. Of course, we do have the estrogen receptor gene within the Blueprint signature, but we have 57 other genes as well. And that is because simply looking at the estrogen receptor gene by itself is not adequate to allow for the full understanding of whether we have downstream signaling. So most hormone receptor positive breast cancers are blueprint luminal, but some ER positive breast cancers are also basal and have no signaling. So this basal subtype is what I'd like to focus on here for a moment. Does this woman have this subtype? Well, it's important to determine that because they're treated very differently. They behave just like triple negative breast cancers. A proportion of ER positive breast cancers are falling into this basal category. They have no evidence of hormone receptor positive signaling, even with very high rates of immunohistochemistry positive estrogen receptor. There are really no specific pathology characteristics to identify this type of patient. They do tend to be higher grade, but that by itself is not a reliable indicator. They have very high chemosensitivity and PCR rates, just like triple negative breast cancer. But also, unfortunately, they have very poor outcomes if they don't achieve a PCR, just like triple negative patients. But yet they fall within the hormone receptor positive category. So here are, I think, important data showing that these are not simply the low ER expressing tumors. These are not just the 1 to 9% low ER tumors that are known to be ER positive, but we don't believe them to really behave like other hormone positive tumors. What you can see here is the range of estrogen receptor positivity by IHC, which extends all the way up to nearly 100%. There is actually no level of estrogen receptor that rules out the possibility that you have an ER positive basal. Estrogen receptor level is somewhat more informative in that it is rarely above 50%. But as you can see, you can have an ER positive, PR positive tumor that is genomically basal. On the right, you see the comparative PCR rates with ER positive basal in the blue column, 34% rate of PCR, compared to immunohistochemical defined triple negative with almost the same rate at 37%. Very different from all the other luminal tumors shown here with a much lower rate of PCR and much lower chemosensitivity. Now, we recently published the 5-year outcomes of this group, and we can show that these ER positive basal breast cancers behave differently than luminal B tumors, even though they both have better outcomes, of course, if they achieve a pathologic complete response. But here, focusing just on these hormone positive basal breast cancers, in red, you can see that if they achieve a pathologic complete response, their outcome is much better, with an overall survival at 5 years of over 80%. But if they do not achieve a PCR, they have the worst outcomes of any hormone positive group, with a 5-year survival of less than 60%. Quite surprising for a hormone positive breast cancer, and indicating that something more needs to be done for these patients, perhaps in the same vein as what we do for triple negative breast cancers. So how aggressive is this breast cancer, and what type of therapy is most likely to achieve cure? Well, here, if she achieves a result that is MammaPrint high risk and blueprint basal, she requires treatment like a triple negative breast cancers. Now, do gene expression profiling assays apply equally to all ER positive women with breast cancer? Not really. The 21 gene assay, for example, cannot distinguish ER positive luminal from ER positive basal subtypes. Within the high recurrence score range, you cannot identify which tumors may be basal and which may be luminal. MammaPrint, on the other hand, combined with blueprint, provides this additional information for the timing and type of therapy that may be most appropriate for your patients, And it is really critical, in my opinion, to find these ER-positive basal tumors because they are actually excellent candidates for neoadjuvant chemotherapy. And while the clinical standard for determining who needs neoadjuvant chemotherapy in the hormone-positive category tends to be larger tumors with positive nodes, if we think of them as triple-negative breast cancers biologically and clinically, then the clinical threshold for considering neoadjuvant therapy in this group would actually be T1CN0, because that is where triple-negative breast cancers are routinely advised to receive triple-negative breast cancer. Another reason to try to obtain this information preoperatively if possible. So with these 5 cases, and I appreciate your attention and consideration as I walk through them all. With these 5 cases, what I have tried to show you is the ways in which genomic profiling with MammaPrint and Blueprint provide clinically meaningful information that supplements pathology in important ways. And so what we are able to do is take, for example, at the top, the main category of ER-positive, HER2-negative breast cancer and separate them into 5 different clinically distinct groups. Of course, the luminal A low-risk tumors, we know from MINDACT may avoid chemotherapy regardless of age. And I showed you those data. For ultra-low, we have shown that you can stop anti-estrogen therapy in postmenopausal women before 5 years in the face of toxicity. And for the low risk that are not ultra-low, this is the group that will benefit from extended endocrine therapy, again, in the postmenopausal group. And then in the high-risk group shown in red, we have this further stratification where not only do we know that there's a chemotherapy benefit, but there's increasing chemosensitivity as the index goes up and the highest rate in ER-positive basals, where we are doing further data to determine, as we suspect, whether it is the luminal B high ones that may most benefit from CDK4/6 inhibitors. While high 2, we believe, may be resistant. They have a high PCR rate. And then the ER-positive basals are a group that really needs triple-negative type therapy. I haven't had the opportunity in this talk to review our HER2 data, but I can tell you that we have 2 important manuscripts being published in the next few months, in which we applied MammaPrint and Blueprint to well-known HER2 positive trials, Affinity and TRAIN2. Lastly, when we receive the results, when we receive the tissue in our laboratory, we are able to provide results within 5 to 7 days of receiving the tissue. Now, we know that distance and other logistical issues may delay the reporting, but as far as our ability to run these samples, we run them very quickly once we receive the tissue. So in conclusion, I'd like to say that our 150 gene comprehensive gene expression profiling provides support for multiple decisions in early stage breast cancer at a single point in time from a single sample, where you can obtain information regarding chemotherapy, management, endocrine therapy, type and duration, as well as timing of surgery and neoadjuvant therapy. And with that, I thank you very much for your attention, and I'll happy to answer any questions as time permits.
Oh, that was great. Thank you, Dr. Audeh, for that wonderful presentation. So we do have some time for questions, and I did see a couple that that came through from our attendees online. So I'm going to go ahead and read those first, if you don't mind. So the first one came when you were speaking about the ultra-low risk data. The first question is, would you omit radiation therapy in node-negative ultra-low risk patients who underwent breast-conserving surgery?
That's a terrific question, because we are actually integrating MammaPrint into radiation therapy trials. We know actually from the MINDAC data, in not just ultra low, but low as well, that there is an extremely low risk of local recurrence in MammaPrint low risk breast cancers that are also clinically low risk, particularly in postmenopausal women. So there's a large trial in the United States known as the DEBRA trial being conducted by the NRG cooperative group, in which a MammaPrint is being integrated as a biomarker. In that trial, they're actually randomizing to omit radiation in MammaPrint low risk, but we're going to stratify by ultra low as well, because as your question implies, it's highly likely that ultra low patients will have the lowest likelihood of local recurrence as well. But we don't have data yet to confirm that. So I wouldn't say that's standard of care. I see another question here, Joe, which I'll just read. And it is asking, do you see the MammaPrint ultra low risk in HER2 positive or basal? And I can say I have not. We almost never see low risk in basal. We do see MammaPrint low risk, but not ultra low in HER2 positive patients. I suppose it's possible we would see an ultra low, but it's rare. We do see low risk in HER2 positive exclusively in the triple positive patients, those that are also hormonally positive. And when we perform blueprint, those tend to be more heavily luminal and hormonally driven. In that case of low risk MammaPrint with HER2 positivity, we actually still advise standard of care chemotherapy and anti-estrogen therapy, because we do not have data showing that one could withhold chemotherapy in a HER2 positive patient. But what we can say is that, and we've confirmed this with the I-SPY data, we can say that they have an excellent prognosis. They'll have a low PCR rate, but they also will have an excellent prognosis, and those data are helpful for that reason.
Great, thanks, Dr. Audeh. So I'll open up to the group in the room.
Question?
Sure.
This blind tumors.
I'm not hearing the question, I'm afraid.
So let me repeat the question.
Yeah, go ahead. I couldn't hear it.
So for the ER positive basal patients, the question was about the treatment for
About whether they are the same group of tumors that we identify as low ER or weak ER, less than 10%, and we treat them as triple negative.
Is the patients we identify as ER positive basal, is it similar to the low ER positive patients that are classified by immunohistochemistry that are treated as triple negatives?
Yeah. Well, in the slide that I showed you, looking at the immunohistochemistry range, we certainly do see that low ER group in there, but they're not limited to the low ER group. As I showed you, the immunohistochemistry goes all the way up to 99% positivity. Over half of the tumors have ER positivity above 30%. And so there is no level of ER that rules out that this may be a basal tumor. So yes, we acknowledge that the low ER expressing tumors, which tend to be genomically basal by blueprint, are indeed best treated as triple negative tumors. But we think the same for those high ER tumors that are genomically basal. They behave the same. And that is why one cannot simply stop at the level of ER, because there are, as I showed you, a substantial proportion of highly ER positive tumors that are still potentially genomically basal. I'll also point out that other assays, specifically the 21 gene assay, rely very heavily on that single gene mRNA from the estrogen receptor. That assay is heavily weighted on that gene. So you may speculate that a tumor that has high levels of estrogen receptor protein will look low risk by that assay, but yet we may show that it is basal and actually high risk. So that is one important reason why we feel relying on any single gene as a heavy determinant of therapy or risk it isn't accurate. That's why we have 58 genes in the luminal signature to separate it from basal.
Yep, more questions.
Positive.
Yep.
Basal blueprint population. The I-SPY2 study, that's where the data came out from. What did the I-SPY2 investigators do for those patients in terms of the neoadjuvant therapy option? Did they receive platinum and docetaxel plus gemcitabine or immunotherapy? Alternatively, does he know, does already know whether there's a trial that's trying to answer that if you are positive for basal type patients, what chemotherapy backbone should they have?
Okay, I'm not sure how much of you caught, Dr. Audeh, on that one. So for the ER-positive basal patients within I-SPY2, what treatments did they receive, and how were they treated differently? Did they receive platinum agents or immunotherapy agents? And for these ER-positive basal patients, is there a trial currently trying to answer that question?
Yeah, great
Appropriate
question.
therapy.
So the data that we have from I-SPY so far did not look at blueprint prospectively. That was a retrospective analysis. So what I did show you was that the MammaPrint high 2 within I-SPY was the group that had a preferential response to carboplatin, to immune checkpoint inhibitors like pembrolizumab, durvalumab, and also to PARP inhibitors. Now, in retrospect, we believe that many of those certainly were likely to be ER-positive basal. And going forward now, I-SPY is in fact stratifying patients not only by MammaPrint risk, but also by blueprint subtype as part of their more extensive response predictive subtyping. So it's an excellent question. We are within a trial that we're conducting within the US known as FLEX. We are specifically looking at the ER-positive basal and the luminal B high 2 tumors in terms of their responsiveness to a platinum-based regimen, which is Taxotere carboplatin, in comparison to standard ACT. So we are in fact generating data looking at the rate of PCR in that very high, genomically high risk group. But we certainly suspect that these patients need aggressive triple negative type therapy. And with carboplatin, Taxotere being a regimen that's now being considered in triple negative, we're looking at it in ER-positive basal. There will also be, based not on ER basal necessarily, but on MammaPrint high 2, there will also be a study looking at neoadjuvant immunotherapy in ER-positive patients that are high 2 by MammaPrint, because that was also an observation, as I showed you within I-SPY.
Thanks, Dr. Audeh. Yeah, great explanation, great answer. I have just two more questions. One more. The first one is that came in through the chat. It was, do you think gene expression profiling will replace clinical and IHC testing in the future? And after that, one more question.
Well, to any pathologists in the audience, my answer is no. I think we will always need to combine these things. They are complementary and synergistic, because while we can look at gene expression and signaling pathways and and understand the deeper biology somewhat further, we still need the presence or absence of those protein receptors to help us guide therapy, especially now with new drugs like the antibody drug conjugates that target HER2, even low HER2, without any HER2 signaling. So the presence of the protein is still important for therapy decisions, and I think I consider them to be complementary and additive.
Okay, thank you. And one last question. You kind of alluded to it on one of your slides, but it was the questions in regarding to recent data that's come out for Oncotype DX showing that in different patient populations or different ancestries, that the test works a little differently, less prognostically accurate. Specifically in Black women, the data has come out from Taylor X and our Responder that shows that. How do you think this impacts the test in women of Asian descent?
That's a very good question. I think what we've learned, and we're actively studying this in that large trial I mentioned to you, Flex, in which we've enrolled 13,000 women of all self-reported ancestries around the U.S. so far, and we're hoping to gain populations of all types. We've learned that there are clearly gene expression-based differences in breast cancer when we look at self-reported genetic ancestry. It's been most prominent in Black women, where there not only have we found differences in gene expression, but we have found that MammaPrint is consistent in its results, unlike the Oncotype recurrence score, that with 150 genes, we're showing that low risk luminal in a Black woman is the same as in a white woman, but not with recurrence score. So what that's telling us is that genetic ancestry affects the biology of breast cancer in some ways. And so we expect to find similar issues in breast cancers in Asian women as well as in Latin women. There's a tremendous amount of knowledge about the population genetics and substructure in these different gene pools. Within the United States, of course, we have women who are self-reported as Asian, but we understand there's enormous diversity there in that large category in which women self-describe it as Asian. We think there's a lot of genomic diversity that is simply too complex to uncover with 21 or 16 genes. So we think we're going to see something similar in Asian women as we study them further, as well as in Latin women, a similar story, we suspect.
Okay, once again, thank you again, Dr. Audeh, for joining us so early over there on the West Coast, and also to the 70 or so participants online. Thank you for taking time out of your day, and to all the participants in the room. Thanks for joining us. Wonderful presentation.
Thank you so much. Thanks for the invitation. Thanks for having me. I hope perhaps in the future I can be there in person for any future such meetings.
Okay, so at this time I'll close the presentation. Thanks again, and for everyone else, please have a great rest of your evening, and look forward to speaking with you soon. Thank you.